Perfect, perfect, just perfect. All three of you, thanks so much. While people are lining up to go to the microphones, I just want to say that what we heard among other important statements was we have questions. Nancy said it, we have questions. Alan said we have pressing questions. I think Lou said something like we have burning questions. So a question for this audience, I think, is how do we as a research community get in better touch with those who are the end users of our research so that we are asking them to conduct research on questions that mean something. I think we heard a message from all three of these representatives of key players that that they see a need for research. I think Nancy said she wished she was walking into a clinical trial every time she walked into the office. And yet, as Alan suggests, a lot of the trials that come down the pike and are presented to him are really don't reflect the kinds of questions that he or his colleagues at Kaiser Permanente would be asking. So I'll start with one quick question to Nancy and just say, since in a sense all three entities seem to be in a similar boat of having questions and not, and not yet being able to see their way forward to really, join in and participate with great vigor. Does anything occur to you that could bring those together, the delivery system, the clinicians, the patients? You talked about in improving the one-on-one recruitment methods, but anything beyond that, ways of partnering?
There's some really interesting work that's been done in HIV trials where they create a community of research. So I think that's kind of the model that works. But that's, again, separating research and clinical care. And I think the real challenge is getting them married instead of separated. I live in a very small town in Oregon, out in the country. And I've talked to my doctor about this. And she says what you both said. I come in, I start running as soon as I walk in the door, and I don't stop running until I walk out the door that night. I don't have time to do anything that doesn't improve our bottom line. And to do a large, simple trial, you've got to change it. Something in that equation has got to change.
Alan, Lou, did you want to add anything to this, or should we go to the microphone?
Well, I think right now it's not clear that we have a forum for folks that represent all the different stakeholders that we've seen today to have those conversations. Even within a singular institute, I'm not sure how well at NIH that exists. But I think that's something I think would benefit, and it would be something that would be a proactive dialogue as opposed to telling one group or another what they need to do, which I think is we really want to try to avoid that and make it much more. We've talked about partnership, but I do think that is. The other thing that Lou emphasized really is time sensitive. So I think it also challenges the way we fund research. And we have to be much more creative, and I think that NIH is trying to get much more efficient and push researchers to be more efficient. I think the FDA, other regulatory bodies need to think hard about that as well. And as Nancy just said, how do you create a community within at least healthcare delivery systems where it is an expectation of that culture of research? And I think that's for people like me and others who live within those systems to push that, but also to have a collaborative forum to have that kind of support.
Yeah, I guess what I pick up from this is the issue. There's a kind of a design principle in kind of how to construct the information infrastructure for a learning health system. And I think we should just be very blunt that we are far from where we are than we need to be. As much as we are promoting the spread and use of electronic health records, I guess I'm struck, and I'm not an engineer, but if you had a kind of system engineer in the audience, maybe there are some, they'd say, well, it appears that whatever infrastructure you have for clinical care delivery isn't designed to do any of this stuff. And if you want it to happen, it needs to be designed in so that clinicians don't have to do anything special to basically collect the data needed to answer the question that's relevant to them. Same thing with patients. The patient should be able to ask a question and get the answer out of the learning health system. Well, there's no capability for that. That's why we see the evolution of patients like me and home and basically collectives that are taking collective action to try and get those questions answered. So there's a design principle, it seems to me, that needs a lot of work.
just add one thing? And it's interesting, the increasing use of electronic interaction between patients and doctors. Patients have concerns about that. Group Health in Seattle did some really interesting work on this and found that patients were afraid to use the portal too much because, unless they were upset with their doctor, because they didn't want to lose that face-to-face time. And I think it's really critical to remember that that's the relationship where all of this takes place. And it doesn't have to, but I think that's the end goal here.
Good. Okay. So let's start moving left with Rob.
Yeah, I want to pick up right where you all left off and try to push you to the next step, because I think you've identified, I think of this, in this area of research, there are two translational blocks. Talked about one in the last session, which is consent, IRB interactions, all that. I think this is almost totally an issue of practitioners and administrators in health systems. Not that it's their fault, but I don't think there's a problem with patients being willing to participate in clinical trials, by and large, if they're asked. But what Nancy described about her doctor is exactly what I hear from almost everybody. And we've had many discussions with Alan just along the line that he described, where we say, we got this great clinical trial, won't Kaiser participate? And his answer usually is, it's a great clinical trial, but it's not really on our list of the 200 top things that we'd want to do. I think PCORI is a good segue into this because you're forcing people to confront this up front. But even if you do that, I still think that there's a problem in American healthcare today, which is distinct from most other areas of the world, with the way practitioners feel about the way they're spending their time. We do a lot of international trials, and we just don't see this in most other countries. If it's an interesting trial, people will do it because they seem to have more time in their day. And I think that's really the crux of the most important issue. How are you proposing that we're going to get through that issue?
Well, Rob, I think you raised some great issues. So you're absolutely right. So in our system, we've looked, and it's an average of 2 hours after your clinic day to complete your notes, and then that doesn't always include all of the secure email messages and phone calls you have to return. Having said that, I think it does raise the question of whether or not the physician really ought to be the pivotal point to engage for clinical trials, or whether it ought to really be a parallel system, which gets back to some of the issues around consenting or not, but why? Why do they have to be the group that always approves and always speaks to the patient about it? Because I'm not sure that's the case, depending on the study. I think if you add any small p to a physician's plate now in the current U.S. system, it is a real problem. It doesn't matter if it's good for them, right? That we think it's good for them. It's still a problem, and it's their time. So I think we have to figure out ways to get around that. And I'm not sure I know the answer, but I think we have to figure out ways to get around it and not make them the fundamental person that has to work to get that patient enrolled.
Bob Ratner from the American Diabetes Association. I want to take this discussion to the next step, and that's how we end up using some of this information. We do an awful lot of RCTs. We publish a lot of RCTs, but the vast majority of our practice guidelines are level C evidence. And so we're not asking the right questions, and we're not interpreting the data in a usable fashion. So it goes to the issue of who's deciding what questions get asked and how they get asked. But I think the other concern that I have is what's been referred to as the tyranny of the mean. All of the data is presented as mean responses. And I don't take care of mean patients. And so how do we move from these large-scale, simple trials with 10,000, 15,000, 20,000 individuals and determine what's going to work for the patient sitting on the other side of the desk from me?
So get the questions right.
Not only getting the questions right, but analyzing it in a way that has much more utility, so that if you've got two interventions, one which works 60% of the time and one that works 40% of the time, the current interpretation in the New England Journal is do A because it's significantly better, except 40% of the people treated with B did perfectly fine.
Ralph.
Glad I don't have to answer the questions. I can ask them. So actually, I wanted to follow up on a comment that Lou made in his presentation when he said quite provocatively, I thought, that maybe it wasn't necessary to do those randomized studies to promote the implementation of some of the interventions in the health system, do it and then evaluate the outcome of it as a prospective but not randomized kind of approach. At least that's what I interpreted from your comment. And then on the next slide, you had a statement that said you needed to randomize to have valid and reliable evidence. So I was kind of wondering which it is. Can you do the prospective evaluation of system-wide interventions without randomization? And as a payer, what constitutes credible evidence for you to act on evidence that would improve either the performance of the system or the care of individual patients?
Yes, I kind of thought you might ask me a question like that, Ralph. And I think the answer is it's much more a function of what is the question that you want an answer to, and what is the reliability of the evidence and its validity and generalizability. When we make medical policy, the thing we generally are looking for that is lacking most often, and it actually gets to the prior question as well, is we just lack high-quality evidence, regardless of what kind of design it is. And so I think, I guess in a certain sense, what you really want to be able to do is specify what are the meaningful questions, what is the best way to get the answer to those questions in a time frame that permits decision making. And I guess, that was a function of what the specific question is. Particularly, the other thing, and I guess the other thing I would say, Ralph, is that particularly for system level interventions, extremely difficult to randomize a system level intervention. You really almost always have to do an intervention and have a non-randomized design to figure that out, because other than some very unique circumstances, very difficult to pull off that kind of design. So that does lead you either to prospective or retrospective observational studies.
Joe, can I quickly? I appreciate Lou's comments very much. I think it is challenging to do that, but I don't think it's impossible. And I think, for example, quality improvement folks don't always speak to the research side. Randomization isn't built in necessarily into quality improvement culture. I think this is a culture shift. And I think that I don't think that there's an inherent disagreement with the need for the reality of randomization. It just isn't what they're usually used to doing. And so when we've spoken to them, I think that you're right. I think what you're getting at is you can't just randomize and say you get this, you get nothing. But I think phased rollouts, I think creativity around adaptive types of designs, I think we need to push that. And I think that way we can move more toward getting the answers that we all want, at least for certain kinds of questions. Yeah.
And I want to emphasize the part about asking the right questions. And I think a lot of people here are academic researchers, so don't all converge on me with knives or anything. But I think the academic research community is a big part of the problem. And Rob Califf and colleagues looked at clinicaltrials.gov and found that a lot of the trials in there were small, single institution phase 2 trials that were there so that somebody could get a paper published. But they weren't ultimately going to do anything to improve patient outcomes. And I don't understand why, not to put you on the spot or anything, why NIH funds research like that. Because I think that we give our tax dollars to NIH to move human health forward, not to get papers published. So.
Maybe that wasn't the study they funded. Maybe that's just the paper that got published.
Yeah, that's true.
Actually, can I answer that? I mean, that's great. I'm so glad that you asked that, because we are asking that question. And to give you an example of this, big problem is sometimes the papers don't even get published. And we've actually analyzed this, looked at our trials, cardiovascular trials, and we're finding that many of the small non-clinical trials don't get published or take a very, very long time to get published. So I think that question that you ask is absolutely spot on. And all three of you, dealt with a really critically important issue, which is that one way to make this happen is that it should be something that you all want it to happen. The incentive should be such that you really want to know the answer, and the best way to find out the right answer very quickly in a robust way is by doing a randomized trial that takes advantage of infrastructure that makes it possible to answer it very fast. So thanks for asking that.
Thanks, Michael. Penny.
Yeah, Penny Moore from the Center for Medical Technology Policy, and I would actually like to put Joe on the spot, but I first want to put you on the spot by basically saying that I think, Alan, it struck me, Alan, when you put the top 200 list, and that some of the things that were on your top 200 list, like you talked about catheter-based ablation for valve disease, are things we've heard about for a while and that have been on the list for a while, but the studies aren't getting done, which I think is why we wanted the creation of PCORI in the first place, and that ensuring that the priorities reflect your needs is really critical. And I think that a lot of the priority setting processes that have been done, like in IOM, have been such broad-based and not necessarily getting really at what the healthcare decision makers need to get at, but get a lot of input. I'm wondering if, Joe, you can tell me a little bit about how PCORI is going to get around that and get to the right questions.
Well, good question, and a lot of people have been asking it, and we are gradually rolling out answers. We did start with a rather broad, inviting set of announcements that really let the research community partner with patients come and make their case for what some of the most compelling questions were. But you need to remember that we were created to address prevention, diagnosis, and treatment questions that are important to patients, and across the entire spectrum of conditions. And it is true, and to have a special affection and interest in rare diseases as well as more common diseases. So we were given a pretty big palette when we started. But we are, and it's more challenging to prioritize with a field of options that large. Nonetheless, we are doing it. We named at our last board meeting a couple weeks ago 3 high priority areas that, based on the IOM and other previous reports, have been found to be high priority. So we actually have 3 specific targeted areas that we will be developing funding announcements on in the next several months after convening expert panels for each. So we are moving in that direction. We agree. We really look for opportunities to partner with other funding agencies on important topics, just to leverage the resources that we have given our mandate. But I am sympathetic to you and to many that say, why haven't you selected 3 or 4 or 5 or 10 high priority areas and just jumped in? And we are kind of gradually moving in that direction, even as we want to stay open to good ideas from fields we hadn't prioritized highly.
I'm a supporter.
Yes, sir.
Gary Filerman with the Atlas Health Foundation, which none of you have ever heard of. 2 comments about the context of your conversation. I think there's a missing person at the table, and the missing person is the CEO of an integrating healthcare delivery system. Every day we read in the literature, if not the popular press, about the consolidation that is going on, the rapid evolution of integrated delivery systems, and several of you have alluded to the impact of the work environment on moving the agenda forward. But the real question is, what drives the work environment? And I would argue it's the culture setter. And that there is an opportunity in this process that's sweeping across the system to engage culture setters, that is largely CEOs and chief medical officers, in the process of rewriting the mission statements of those organizations to make clinical research an explicit purpose. That's point number 1. Point number 2, every time somebody has alluded to the barriers to conducting clinical research in the practice setting, everybody's just gone along with the notion that you have all these practice barriers. But we all know that there are group practices across this land that are doing excellent clinical trial work. They've developed business plans which align their objectives and their behaviors to deliver what we're all saying you can't deliver. Now, we got to look at those groups, and we've got to learn what it is that they've worked out, how they worked out their financial models, their practice models, so that in fact, clinical trial participation is central to their business plan and they are successful.
Excellent points. And if you have any ideas on exactly what you say to the CEOs to get them to sign and then to really mean it after they sign and change the culture accordingly, we should talk. I mean, it really is, you're absolutely right, it's not going to change without that. Nancy.
About 15 years ago, NCI looked at high accruing sites across the country, and they found a place, I think in Kansas, where the accrual was through the roof compared to everybody else. And it was because there was a nurse there who every morning made out index cards of what trials were open and put them in the doctor's pockets and said, remember to talk to your patients about clinical trials. So it doesn't have to be high tech, that you can, an index card.
So I think those are great points. The thing about the second point you made, which I think would be interesting, is whether or not you can learn from those kinds of practices who may enroll, let's say, 20 patients into a study when you're looking to enroll 20,000. Mm-hmm. And whether or not the practices that are within those kinds of settings, very efficient, although I think would be financially even more challenged as we go forward, can those be scalable models? And I think it's worth looking at because that's the issue, is when you come to a health system like United, can you do it across that many practices in the same way and be effective without overburdening the clinicians, for example? And I think we should challenge that if it's possible.
Hi, Bill Crown, Optum. One of the issues that's come up in many of the presentations is this issue of different study designs, randomized study designs versus observational study designs, prospective and otherwise. And I just wanted to make a comment that's more of a statistical nature. And that is, if you hypothesize that there's a certain set of factors that influence an outcome of interest, and you actually collect data on those outcomes and on the predictors of those outcomes, whether it's randomized or not shouldn't matter. You should actually get exactly the same treatment effect in a non-randomized study as you would get in an observational one. So the issue is, in an observational context, you often don't know what you don't know. So you end up with these confounders that end up biasing treatment effects. But it's quite possible that that's more likely to happen in certain disease areas than it is in others. Like maybe if you have strong clinical expectations for treating HER2-positive breast cancer, for example, it's a select set of clinical factors that are highly predictive of the outcome. Another condition like some sort of mental health condition, there might be huge variability in it. So your ability to actually be able to get reliable evidence for certain kinds of conditions from an observational context may be considerably higher in some disease areas than in others. And you might not need a trial of any sort for those conditions as long as you have, as Lou was saying, kind of the data infrastructure to be able to capture the data. And then in an observational context, of course, there's tremendous advantages in terms of the ability to slice and dice very large sample sizes. So perhaps one thing we should think about is creating the evidence maps under what conditions do we actually get the same answers in observational study designs versus randomized study designs. And then we don't need to worry about those going forward so much. And we can reserve the randomized study designs for conditions where there's a lot more variability. I'd be interested in the comments of the panel on that.
I'm just going to take the chair's prerogative not to address that question in any great depth. I think right now, just because it's not quite what we're here to discuss this hour and the hour is just about past. But I think everybody will agree with you that if we could just decide when observational studies were appropriate and when you needed trials, we'd be well ahead of where we are right now. John.
Yeah, John Steiner from Kaiser. I may be asking or making the same comment in a different form, but it's certainly something that we or research directors in Kaiser have been wrestling with, which is that I've been staring at this title slide all afternoon and saying that large simple trials are a component of knowledge generation in a learning health care system, but are they the only component? It's part of a question about our purpose here. If our purpose is how to design better, large, simple trials, that's a laudable purpose, very important purpose. If our other question is how do we help organizations learn, there are actually a lot of ways to sort of increase the learning within a system apart from randomized trials. And just a couple of examples. I think that an issue of interest to both operational leaders and researchers is the question of variations in performance across health systems. Why is blood pressure control better in one Kaiser region than another, or in one office practice than another, and so forth? To address that actually with any degree of validity, although it's an observational question, requires very rigorous statistical control for differences between sites and so forth. So if we agree that that's a valid operational question, we can help organizations learn by improving the rigor of their statistical models without teaching them how to do large simple trials. Similarly, if quality improvement groups are trying to improve the quality of care within an organization, there are rigorous quasi-experimental designs, step wedge designs, and other things that we can, that are actually, I think, more acceptable oftentimes to operational leaders that we can encourage them to use. And then there are situations where the randomized trials are compelling and really there's no good alternative. So I guess the question that results from all that for the panelists is, what is our goal here, or what do you perceive the goal should be? Should it be to help organizations learn by any means necessary, or should it be to really focus on the large simple trial as the mechanism for organizational learning?
Okay, since I didn't let Bill get an answer to his question, and your question is pretty much the same question, perhaps we should just, it is true, no doubt, that there's a lot to learning health systems beyond random, large, simple trials. On the other hand, there are a lot of instances where randomization is going to be essential, and my sense is that we're here to talk about that today. I also know that our time is just about up. I see that that last comment got Bob Temple.
Well, no, I won't talk about what I was obviously going to say anyway, except to remind people that one of the uses of these large trials is to go get good data on something that an observational study suggests. That's a source of things to do.
That's right, and I think you can say the opposite too, that the good function of observational studies is often to point to the next trial that needs to be done. Yeah, so
the only thing I'd say about that, and it also gets to the issue of heterogeneity of treatment effects, you could look at observational data as hypothesis generating, and there are two approaches to, and the aim is, in a learning health system, you could then follow that up with a large, simple randomized trial to confirm the finding. Alternatively, you could actually, in a learning health system context, actually take the hypothesis that has been generated in the observational study and test it in actual practice and follow along in an actual real-world delivery system and seeing what you find. I mean, it's another way to approach learning is the point, I guess, that should be out there.
Oh, thanks. Mike, did you have a question?
Yeah, well, I would add that the CEO question is a very interesting one because it gets to the heart of this. There have been some analyses that have suggested that an integrated healthcare system that's responsible for the long-term care of their patients has an incentive to know what the right answer is. And if the best way to get the right answer is to do a randomized study, then they should have an incentive to actually get that done. And in fact, in many businesses, that's exactly what happens. I have a very good friend who works for a gigantic retailer, and we were talking one day, and he said, "Oh yeah, I do randomized trials. That's what I do for a living. We collect data on everything. We have a gigantic observational registry on essentially everything that they do and everything that they sell. And then in order to know what works best, in other words, what will generate the most number of sales for them and generate the highest profits, they do randomized trials. And they know that that's the way to do it, is by doing randomized trials. That's how they're going to get the answer that is most likely to be correct. So it's built in within their culture, and it's not something that they're doing out of academic interest. It's something which they're doing because they have a direct incentive to get that. And one can imagine if we could have a world here in which the world of patients and the public in general are demanding the best way to get the answers, and the CEOs are also demanding the best way to get the answers, and the payers are demanding the best way to get the answers, then we'll get it done.
Yep. Well, Rick and Ralph, I think, or Rick and Dave, I think our time is about up. It's just I just wanted to close by pointing to a couple comments that we heard a lot. The first was that we have questions, that whether we're patients or clinicians or systems or health plans, we have questions. I got to say, I did not hear much from the research community gathered in this room in response to that. I did not hear anyone suggest that there might be ways to tap into those questions. I'm glad that at PCORI we're working on that and take it very seriously. But I think, you know, more broadly, this notion of conducting research that addresses questions that those people that use research have is worth a lot more consideration than we gave it today. And the second is this notion of the Alan called it the culture of randomization. It was suggested that to get that, CEOs need to get it, and Mike suggested how CEOs and other organizations do get it. So I think that combination of greater receptivity on the research side to the questions of these users, patients to CEOs, and hard work with the CEOs who I completely agree, have the power to change culture, seem together to hold promise for more and better large simple trials. So I'll turn it back to you guys. Thank you very much to the panelists.